No, we already went on through it. Well, I want to welcome you all. Frugality being what it is, the air conditioner will be turned on May 15th. That's true. Actually, that's true. We did ask, and that's what we were told. So, welcome to Frugality in Action. Hope you brought a lot of water. We have quite a bit to do. We still have some testifiers from yesterday. And if Mr. Larson and Mr. Nelson want to come up, I don't know what you've been told for time, but 2 minutes works for me. And the time you're spending telling us the things we already know was just eating into the evening. We're going to be here for sure tonight. And in terms of order, I think I'll have Ms. Perry come at the end because I think we'll take up that amendment just so it can be talked about while she's still here. And so people interested in leapfrog, just to respect people's time. I don't know if Mr. Mass is here, wants to talk about it. If Ms. Braze is around, I know that's on their minds. They have opinions about it as well. So we'll put that at the end just to get that discussion properly done. We will be taking testimony on a few amendments, although not many. If a member really wants to have testimony on something, I will, certainly honor that request. Which means if you jump up and down real a lot, and then maybe they'll notice it and they like your testimony, then they'll ask you to come down and say something. If we're just totally way off track, I'll apologize, and maybe you want to just run up and tell us that we really missed something. Minutes, just to keep us all in agreement. Representative Liebman, do you want the honor of having this marquee moment to do the minutes again?
Well, I don't know, Mr. Chair.
Is that too big a responsibility?
I'll do it really. I'm pretty quick study, so let me see here. Okay, Mr. Chair, I think I could safely move these minutes.
Okay, thank you. Any discussion? Anybody wish to testify to these minutes? Seeing none. Mr. Nelson, do you have an opinion? Are you okay? Okay. All in favor of the minutes, please say aye. Aye. Opposed? We're off to a good start. We have some 70 amendments, and our general plan is to not do them in any particular order. I've gotten a list from Representative Huntley, which I lost already, that some things they want to work on. And so when we get to that list, get to those, we'll take those up. We're going to go through all the amendments people want to go through before we stop. And so don't worry if you didn't get picked early. The only thing bad is if your lobbyist is waiting in the audience till the last one, and that's too bad for them, I guess. And so just to give advice to people, let's see. They all know what they're talking about. I think all the testifiers are aware of the current status of the bill. So and if you can be sure to testify to the bill and to state that it's in, along with the things I mentioned yesterday, that would be productive. And I think I'm going to stick with 2 minutes, except for maybe the leapfrog thing. That might be a discussion that people want to engage in a bit. So with that, Mr. Larson, welcome to the committee.
Thank you, Mr. Chair and committee members. I'm Steve Larson with the ARC Minnesota and the Consortium for Citizens with Disabilities. I had about a half dozen compliments on things that we liked in the bill, but
take all the time you want for those.
You've heard that ad nauseum about how good several parts of the bill are, so I won't cover those per your instructions.
Larson, the word nauseum and compliments don't belong in the same sentence. So compared to, just think about a year ago. A year ago you were here in much the same week. In a different status.
So thank you for those great things in the bill, Mr. Chair. I did want to address, we ended yesterday, I think, with some confusion on the 20% relative personal care assistance, and that is, I want to be clear that that is not in the bill, fixing that, and that is something we would like to see during this process as we go forward to see if we can address that. It was in House File 2901, and this does impact over 6,600 individuals that provide services. Mr. Hoffman had clarified that there are some forecast changes that were made because of the court action that took place, and so there was some savings that wasn't booked as a result of that, but he does book savings starting on January 1st. So I just wanted to be perfectly clear that the 20% PCA relative cut is not fixed in this particular bill. So thank you for
Mr. Larson,
that
to clarify on that, just since I'm trying to help people know what we did and didn't do, and you can say if you like what we're doing or not. In my understanding, the 20% relative PCA reduction is put off until January 1st of 2013 in the forecast. They're not taking any savings for it. An amendment coming, which I think is in the pile somewhere, will state that whatever the judge decides, whenever they decide it, is going to be a decision going forward, and which would imply that any provider, any operator holding funds pending a clawback should release those now to their employees. So that is in the bill. So and you can continue. So
thank you, Mr. Chair, for that clarification, and that's the way we understand it too. So that's one issue that I was going to deal with. The other issue that I think is most important that I want to express some concern about was the savings coming out of the home and community-based service system, or corporate foster care. At the end of with the bill that passed back on July 19th or 20th, there was a surprise in there about the closure of 128 corporate foster care beds, and people have been working with the chair to try to fix that situation, and we've done that by coming up with a need determination process that would help with that. But the current bill goes beyond that and takes further savings up to $4.4 million rather than the $1.8 million I think that we were originally at. And so again, we're having some reduction in services in corporate foster care. Yesterday we had testimony from individuals that have concerns about autism and their needs not being met. We still have the problems with the 10% congregate care cut that also impacts corporate foster care. So we have cumulative cuts. The money is going to be used to fix things like medical assistance for employed persons with disabilities, and we applaud that and are glad to see that's fixed. But we want to be perfectly clear that this money is coming out of the waiver program and more specifically out of corporate foster care, so we'll be shrinking our capacity in that greater. And so we wanted to get those concerns up. So again, Mr. Chair, thank you for the good things that are in the bill, and we look forward to discussing these items as we go forward.
Thank you. Maybe Ms. Holste and Ms. Thurlow can be on deck. Mr. Nelson, welcome to the committee.
Thank you, Mr. Chair, members of the committee. I am Bruce Nelson from ARM. We represent disability providers. First off, I do want to thank you on a couple things. The 1.67 cut, although it's an interesting solution, but it works, and we thank you very much for that. We thank you for something that is not in the bill, and that's the fee that would be related to another section and statute and the regulation side. A couple things. One on the size and setting that's in the bill, Mr. Chair, that's at 25%. We would like to work with you on setting a base of 4, because the way this works, if you have between 1 and 7 units in the building, you can only have one person.
Mr. Nelson, I agree with that entirely. So can you make sure that that's held harmless through the process?
We'll try.
There's no effort to change that. So please help us make sure the language works for that group.
Mr. Chair, as early as this morning, we were talking to the department, and they say that would be a fiscal note. So we will work at your direction with the department. Thank you. The major concern I have, it was expressed by Mr. Larson, and that's the money that would come, we presume, through bed closures that is now $4.2 million. The language that was a surprising session was 1.3 for 128 beds to be closed. With this new language, this new number, we'd estimate around 400 would have to be closed to reach that number. And as Mr. Larson said, that money is paying for other things in the bill, and we are uncomfortable with that, seeing the various disproportionate hits we've received. On the 10% cut, we would have to realize that full savings through all those bed closures before there could be any changes on the 10% to 9 or 8. And that's very concerning to a lot of us, especially those who provide services to people who are mentally ill, AIDS, HIV, and people with developmental disabilities. So with that, Mr. Chair, there are a number of other things in the bill that we do indeed like, but we have concern about that, and I just got the spreadsheet and some of this morning, so I may, as usual, or as often, misunderstand some of the items in the bill.
Mr. Nelson, I appreciate your concerns, and you know I listen to them a lot, and so do the members. So thank you very much, and I appreciate there's some good things in the bill. So we're all trying. Thank you. Ms. Thurlow and
Not heightened.
don't look heightened. Okay. Very good.
Although I
Welcome
play
to
her
the
on
committee.
TV, so maybe that'll work.
Yeah. Okay. Welcome.
Mr. Chair, members, my name is Toby Pearson. I'm here with Care Providers of Minnesota, here with our partners at Aging Services. We have just a few comments we'll make about the bill, and then we'll be ready for any questions. First, I'd like to just acknowledge that we really appreciate the target of 0 this year compared to last year, which is very nice. We acknowledge you did a lot of work last year, especially on older adult services. A couple things we do like, as you mentioned yesterday, we like the moratorium funding. The $1.5 million does generate a gazillion or bazillion, I'm not really sure. But the real number is actually approximately 2,500 jobs and $311 million in economic activity. So you really do get a big bang for your buck on that. We'd like to also acknowledge...
This is a jobs bill, then.
I think we can call this a jobs bill. We'd also like to acknowledge the repealing or shifting or delayed repayment of the 1.67. You've worked hard to address that. That's been a concern for a number of our providers. We'd just like to thank you for the work on that. And lastly, we'd like to thank you for including what we refer to as the Elderly Waiver Simplification and Reform Act, which is allowing input and exchange of information on the assessment and support planning for those folks on elderly waiver. So we'd like to thank you, and now I have to turn it over to Carrie, who gets to tell you the stuff we don't necessarily like.
You got the good job. Welcome to the committee.
We flipped a coin for it.
Mr. Chair, members of the committee, thanks for the opportunity. My name is Carrie Thurlow, and I'm with Aging Services of Minnesota, and as Toby mentioned, also representing the long-term care imperative. There are two serious concerns that we'd like to touch base, and first I want to thank Representative Abeler for his willingness to work on both of these concerns. I think as the bill moves through the process, we'll continue to work on both of these, but do want to thank for the dialogue and for the discussion on both of these issues. But for the benefit of the committee, the two concerns are, first, in Article 4, Section 12, there appears language that requires all customized living participants must have a private bedroom unless they choose to share a bedroom with no more than one other family member, except for participants who live in customized living settings that limit participants to 2 people or more. This provision is new. It hasn't received a full hearing, and quite honestly, I think we need a full hearing to understand both the scope of the issue raised and also more study to avoid unintended consequences. While assisted living establishments might vary in size and settings and in services and costs, they all share a common philosophy, and that's that every individual should make informed choices about where they live, what kind of help that they need, and that each individual should live with maximum independence, dignity, respect, and privacy. And while we do not necessarily oppose the concept of individuals having their own space, these are definitely decisions that where cost also comes into. And this particular proposal may have some unintended consequences. Certainly, we would support changes to the law that would make it more clear to provide informed consent, that if a consumer was in a situation where they could no longer afford to pay the rent in the unit that they're living to and may have to move, we're certainly supportive of that and are working with the author on that particular language as we speak. The second issue that we'd like to spend a little bit of a quick moment talking about appears in Article 4, Section 9. This relates to what has commonly now been referred to as the mandatory consultation law. Our concern is that while the language in the bill does attempt to make some exemptions to the current law, it still retains the requirement that a senior must call the senior linkage line and obtain an 11-digit verification code before they may sign a lease with a housing with services provider. Currently, there is no way to avoid making the call to the senior linkage line, and at a minimum, we're hoping for a more efficient process where if a senior does not want the long-term care options counseling, that they can simply sign a form to opt out. We're currently working on some language for an amendment and hope for some additional discussion on that issue later today. So thank you.
Thank you. And to your first concern, we just were talking about this recently, is about half an hour, 45 minutes ago. It seems that this can become a matter of contract. This two people in one bedroom thing, and so people are, at least they're disclosed about what will happen when they do spend down, which actually creates a very good discussion on the way in to these places, which might actually serve part of the function of what the consultation has been doing, where people have to talk about what happens if I come and, if I spend it all, I have to wind up there, really, and at least that way they're fully informed. So I think it's created a good dialogue, and I'm happy about that. I think we'll circulate an amendment later that we cannot pass today because it's past the deadline, but that we'll likely adopt in Ways and Means, assuming we come to agreement on the concept. So I thank you for that.
Appreciate it, Mr. Chair.
Okay, Mr. Lehman and then Ms. Weeks.
Thank you, Mr. Chairman and members. Tom Lehman testifying on behalf of the Minnesota Academy of Physician Assistants. And if you want to open your hymnals or books to page 1 and page 7, that's where my comments will be directed. Again, Chairman Abeler had a bill a few weeks ago related to the problem of physician assistants not being able to serve Medicaid enrollees. Again, physician assistants can serve Medicare beneficiaries in Minnesota for all services, including mental health, commercial patients for all services, including mental health, Medicaid patients for all services except mental health. So the issue is, how do we increase access to mental health services, particularly medication management issues for people who are mentally ill in Medicaid. The issues I just want to highlight, Section 1 on page 1, Mr. Chairman, we appreciate this. This is providing that July 1, physician assistants can provide mental health services on an inpatient basis. If you turn to page 7 and continuing on to page 8, there were questions among some stakeholders and the DHS and some advocates about the appropriateness of physician assistants immediately serving Medicaid patients on an outpatient basis. So you'll notice on page 8 that there's an interim work group set up to bring together interested stakeholders to talk about how we allow physician assistants to provide those services. The question we have, Mr. Chairman, relates back on page 1 in section 2. The new language, payments for mental health services covered under the medical assistance program that are provided by physician assistants shall be 65% of the rate paid to doctoral paired professionals. On Friday, we got an email from the department saying this percentage would be 80%. We were a little surprised to see that it's 65%. We're trying to get that straightened out. The other issue relates to doctoral prepared professionals. It's our understanding, and I understand, Mr. Chairman, it's your intent that it should be a percentage of the psychiatrists, not a PhD psychologist or marriage and family therapist, who do not provide medication management services. So we'll continue to work with the department and you, Mr. Chairman, on that, and we appreciate your support.
Well, Mr. Lehman, I think we can get that worked out today to make sure the language is clear. Those would be oral amendments to something that's fully contained in the bill. The fiscal note, and it's my intention that it would be 65% of the psychiatrists, which they're training at 80%, and I know the codes are all different. We've talked about that a bit. So there's no talking codes. It's all medication management codes, which the psychologists don't do.
Right.
But there is a scale at the department that they scale this off of. The psychiatrists have an enhanced fee, which gets them to the 100 compared to 80. We did that some years ago. Do you have a question? Okay. And so we want to make sure it's clear about that. And so if you can, I'd like this has been a good project. The fiscal note with the 65% saves $13,000. So I think the choice you're going to have is, do you want to do this or not? And so if you can talk with the department, which I think that we have plenty of those staffers here today who are eager to do something besides listen to testimony, although I don't know why they want to not. But so we'll work on that. Thanks.
Thank you, Mr. Chairman and members.
Ms. Weeks and then Mr. Koppel. Mr. Koppel here, he can come down too. Is Ms. Weeks here or not? Well, then Mr. Koppel. And then on deck is Mr. Deal. Is Jim here? I'll let him testify later if he wants. Mr. Deal, you want to come down? And then Dr. Sokolowski, if I said that correctly. If you can be on deck. And then I'm going to ask Mr. Anderson to come down with his crew from the senior linkage line while they're still here. And And so, Dr. Sokolowski, you can sit at the table if you're here with Mr. Deal. So you can come down and sit there. Just kind of, Representative Liebling.
Thank you, Mr. Chair. Just before we go on, we were a little confused about what documents we're working off of here, because in our packets we had this DE3. I think Mr. Lehman was talking about the DE2.
The DE2 is one of your amendments, so there's a... The DE2
Oh, I
is the
beg your
base bill.
pardon. Okay,
So
so
that's
we're
the-
working off the DE2.
Yeah,
I just
and just
wasn't
so
clear.
the audience knows, the DE2 is the base bill. Every amendment will be built on that. We'll be amending DE2 all day. At the end, we'll be approving, hopefully we have enough votes to approve it, the final version of DE2 as amended, and then that'll become the base of the bill. A few others had a better idea. They preferred another way, which was the DE3, and we'll discuss that, I think, later. So, Mr. Deal, welcome to the committee.
Mr. Chairman, thank you. My name is John Deal. I am here representing Gillette Children's Specialty Health Care. We have an interest in many provisions in this bill. I would like to address two provisions that I think are in here. I've picked up most of the amendments. I've only been able to memorize half of them, but the two things that I believe are being addressed that we want to comment on are care coordination and the payment for postgraduate medical education. The provision on care coordination, you've heard what Gillette does on this before. I won't repeat that, but it is an important service that we provide to patients and families, and this seems to recognize the approach we take as well as the healthcare home model, and we favor this. Secondly, Gillette is deeply involved in graduate medical education. We expend about $1 million a year in funds for that. Without the MERC program, that is a pure public service expenditure that is difficult for a small hospital like ours to sustain. So whatever assistance can be given in funding that program will be very much appreciated, and I know that that's something you're trying to do as best you can. This bill presents a teachable moment on two other points that I would like to indulge in. I noticed that apparently in your session last summer, I think that's where it was introduced, there were personal liability obligations for people who have benefits under so-called TEFRA. TEFRA program, from my point of view, is a way that society, at least in Minnesota, but it's a nationwide federal program, the way society spreads the unusual costs of extraordinary medical costs for, in our case, children with disabilities. And the commercial insurance industry has responded to this and other similar programs like MCHA by excluding people and excluding levels of service that are outside the norm. To my way of thinking, that's an acceptable approach in operating private insurance, in that it keeps the services financed through that mechanism affordable. It takes those unusual cases, the person that has extraordinary disease, people that have services that go beyond the norm, in our case, extensive rehabilitation and assistive technology. It takes it out of that funding pool and puts it, in our case, in the Medicaid pool. By imposing, so you cannot buy insurance for services covered by TEFRA. It's almost definitional. If it's in TEFRA, you can't buy insurance. And I see the note. The point is here, by having a copay for, as I read the bill, for example, a family of four, let's say, that has income of 900% of poverty, they have to pay 15% of their adjusted gross income as a copay. That would be a bill of $20,000 for extensive services, let's say, and you cannot buy insurance for it. This is not something we're going to deal with today, but this is a problem. It's a problem for our families and patients, and that's something I wanted to bring to your attention. And I'll let my other point go.
Thank you, Mr. Deal. And this year, the bill only deals with TEFRA in terms of continuing the same reductions into the tails that already, or the same pricing that continues today. So those were from some years ago that we just continue those forward. There's no change in any fees here, just for your information.
It was a surprise to me, Mr. Chairman. It's a teachable moment for me.
Yeah, I mean, it's pricey, and it's kind of based on ability to pay. So if they help out with their own child, and it's a challenge, and some of those families are extremely challenged, and I know that too. So thank you for your testimony.
Mr. Chairman.
And Doctor, welcome to the committee.
Thank you, Mr. Chair. I'm Joe Sokolowski. I'm the Director of Medical Education for the Children's Hospitals and Clinics in Minnesota. I'm also a pediatrician and a pediatric endocrinologist, and that may sound like a foreign term, but I take care of children with diabetes as well as other hormonal and endocrine problems. And first of all, I want to thank the Chair and the committee members for giving me the opportunity to provide some testimony here this afternoon. I have four goals in my few minutes. One is I wanted to thank Chairman Abeler for including in the bill some restoration of funding for MERC, the Medical Education and Research Costs Fund. My second purpose is to outline specifically what the cuts in last year's MERC budget did to children's ability to help train medical specialists. And thirdly, to encourage you in your further discussions and deliberations to understand the critical role that MERC plays in training physicians for the state of Minnesota. We do not have the ability to recruit physicians to come to Minnesota like many other states do, so we have to train our own people. And Children's plays a critical role not only in the training of pediatricians and family physicians, but in a variety of other pediatric specialties, including surgery, heart and lung care, infectious disease, and child abuse. We have programs, we have residents coming to our programs from 29 different institutions within the state, which includes the University of Minnesota, Hennepin County Medical Center, and Regions Hospital. So I'm not speaking solely for Children's in this case. At any one time at Children's, we had between 45 and 50 trainees on one of our two campuses, and in the course of the year, we had over 400 individual residents spend time at Children's learning pediatric care. And I think it's important for you to understand that when medical students graduate from medical school, they have to spend between 3 and 7 years in additional apprenticeship training, learning how to take care of children.
Doctor, just, 2 minutes goes really quick, and I'm glad you're here, and I don't want to minimize the value of MERC, and all right. If you can just kind of help us with...
I'll cut to the chase.
Thank you.
The reduction in MERC last year forced Children's to notify 13 different programs that we could not continue to support the training of their residents. That means that at least 7 trainees who would have gotten clinical experience at Children's will no longer be able to get that, and that in turn may force those programs to reduce the number of trainees that they have in any one given year. I can't tell you how critical it is to train not only primary care pediatricians, but pediatric subspecialists who are going to provide the help and support for primary care pediatricians caring for the children with the most serious and complex diseases.
Doctor, what's the face value of the programs that you think you may have to not do?
The face value?
The cost.
The MERC cuts cost Children's close to $3 million in reduced revenue to support graduate medical education.
And so I know you're a large group, and you understand the challenges that we're under. You also may understand the House was tried to preserve as much as we could of it. Inspired somewhat perhaps by my Representative Huntley, who certainly has had an impact on my view of that. So he's been touting the benefits loud and long. I don't see, we are trying to put $1 million back of the little money we have, and you heard the opposition to even using the source of funds for that purpose. So you understand the challenge we're under. I don't know what in the future, if you look at the deficits that are coming, which I'm fearful of, and maybe we'll grow our way out of this, which would be really nice to get back to flat. You can predict as well as I that it's going to be hard to get back to the levels you were at with MERC. And so how do we handle that as policymakers and as fiduciaries for all the state's money. That's maybe rhetorical, but do you have a thought about what might happen in the future, and is there some other way that we could decide to fund these important activities?
Well, I think unless we come up with a new way of supporting graduate medical education, the end result is going to be fewer trainees who will be able to get their clinical post-medical school training in the state of Minnesota. That will then result in fewer physicians available to man the clinics and the hospitals throughout the state, particularly in rural Minnesota, where a small reduction in the presence of physicians has a dramatic impact on the ability to provide care for the population.
Okay. Representative Huntley, do you want to say anything while we're on the topic? I wasn't being clever. Do you want to offer it? Because we're going to move on then, but I wanted to.
Well, again, for the members, when the people that have got their MD degree and are now doing these residencies, they're usually in a clinic or hospital, and they spend a lot of time talking to the physicians that are already in that department. And so that they use up the time of those physicians, so they're not generating as much money for the institution that they normally would. So there is a cost to the institution that trains these people, and that the Merck money is an attempt to basically reimburse them for those costs. And as the doctor said, if they don't have enough money, they're going to have to reduce the number of physicians going through these residency programs.
Yeah. Well, thank you. And we wanted to give a good plug for so I hope everybody understand the importance. So I think you've accomplished that. So thank you, Doctor. And who do we have left? Mr. Anderson, are you here with your? Yeah. Why don't all of you come up just for a minute? And they weren't on the list, but it's a topic that we had some testimony about before from the imperative folks about this consultation. And so could you spend 2 minutes or so just helping us know the successes and why would we do such a thing as have a consultation like this?
Of course, Chairman Abeler and members of the committee, thank you for the opportunity to be here this afternoon. My name is Bob Anderson. I'm the Associate Director with the Metropolitan Area Agency on Aging, and with me is Pam Zimmerman, who is the Information and Assistance Director at the Area Agency on Aging. And we thank you very much for, again, the opportunity to be here. We are the provider of the senior linkage line services in the 7-county metro area, and we thank you for the opportunity to just share our perspectives of long-term care consultation expansion and other information about consumers' experience with our service. Knowing we just have very limited time, I'm going to turn it over to Pam for just a couple of examples of the work that we have done to date around the long-term care expansion and providing individuals with information and options as to make future decisions on.
Thank you. As the voice of senior
tell us your name, please.
Oh, thank you. I'm Pam Zimmerman, the Information and Assistance Director with the Metropolitan Area Agency on Aging.
Thanks.
You're welcome. As the voice of the senior linkage line in the metro area, our aging experts consulted with more than 33,000 older adults and family caregivers in 2011. The professional staff members that comprise our information and assistance team have many years of experience in all settings of care and talk with hundreds of older adults every day on the senior linkage line. Growing old isn't always easy, especially as one faces physical and cognitive declines. Older adults want information, and the state is ensuring they get it from a neutral source with no vested interest. Seniors frequently tell us that everyone should know about the senior linkage line, that our aging experts are responsive, and that we provide invaluable information that helps them make important decisions, whether it's about health care coverage or how to get help when the burdens of 24-hour caregiving for a spouse or parent take an overwhelming toll. The expansion of long-term care consultation services makes it easy for all older adults to get information, if they want it, about a critically important decision that impacts their lives. If they elect not to pursue consultation, they simply decline and go forward with a move to an assisted living. However, for older adults and their family caregivers who accept consultation, many learn for the first time that local service providers offer reliable, often more affordable community options that can be arranged to help them stay in their current homes. Our experts work with callers to identify the senior's desires and take the family's wishes into consideration, offering solutions and support so that whatever the older person and family feel are the right services or residence options, they can be identified and then pursue. For those seniors who move to assisted living and want help understanding their service package, our information staff provide help to help them make smart decisions about their choices and get them started on planning ahead for when their health needs or other circumstances change. My testimony will conclude with case examples to illustrate our services. First, I'll introduce you to George. George called on behalf of his mother, Helen, who lives in northern Minnesota, to get a code. Helen was having difficulty at home because she could no longer manage the upkeep it required. So she and her family believed that moving to an assisted living facility was the only solution. George was elated to discover that chore services are available in his mother's area, and he knew she would be too, as it was her wish to remain at home as long as she could. Through the information provided by the specialist, Helen remains living comfortably in her home with the services and supports that she needs. And finally, I'll introduce you to Bridget. Bridget was looking for information for her friend, Jamie. Jamie is caring for her 93-year-old mother, Dorothy, in her home. Bridget knows Jamie is highly stressed and has a hard time making phone calls or taking on additional tasks, so she was helping her to gather information. Jamie was just beginning to think about moving her mother to a housing with services setting, though she really preferred to keep her mom at home. They weren't sure how to begin with the process. We helped assist Bridget by going through options for in-home services, including homemaking, home health aides, and even housing with services options. The use of a caregiver support program and how that could support and help Jamie as she navigates the options and makes choices with her mom was also discussed. Bridget was relieved to know there were so many options available to her and to her mom. Thank you for hearing me today. I'm happy to take questions.
Well, thank you, and I think it's been helpful. Because some of these things occurred rather suddenly at the end of session. And so, Representative McDonald, do you have any questions about this? I know you're working on this topic. Offhand, do you have anything?
Yeah, thanks, Mr. Chairman. A question for the testifier. What percentage of folks are opting out of the availability of knowledge for long-term health care, long-term for the providers?
I'm sorry, I don't actually have the percentage information with me today, but we can certainly get that information to you.
But can you just give some idea? Do most people, like over half, take the consultation, or just a ballpark? You don't have to have like a percentage, just a ballpark.
Sure. I would say a ballpark is that many people do opt out and don't really want the counseling because they don't really know what it is. And oftentimes, as we talk to people and help them understand more about what we can provide, they're more willing to accept it.
Mr. McDonald?
Yeah, thank you, Mr. Chairman. Well, I understand the importance of the program, and it seems that could be making some headway in educating the consumers of their options. And certainly it's a great intention of all parties, for the most part, to keep a family member at home. It's a lot less costly, and a lot of folks don't necessarily want to leave their house and have to go into other facilities. So I recognize the importance of it. I did have some concerns regarding the mandatory call before one moves their loved one out of the home and into an assisted living. So I was just curious as to the opt-out. So they all have to call, but it seems like there's a good portion of them that opt out of getting the information. So based upon that comment, when you said not many of them understand why they have to call or they opt out, what maybe in the program is not working? And I'll preface it with this: if I was to call for a loved one and get the information what's all available to me and to my family member, I wouldn't opt out necessarily right away. I'd want to hear the information. Why are they opting out so quickly?
Ms. Zimmerman.
Thank you. Mr. Chair and members of the committee, I believe that people are opting out because many of them have already made a decision and we're getting to them too late in the process. We really need to get people further upstream before they're ready to sign on the dotted line, to sign that lease. And so I think that that is one key strategy we need to address in getting to people sooner, getting people the information and education they need much sooner in the process.
Well, thank you.
Yeah, Mr. Chairman, just one more question.
Sure.
Thank you. We passed this last year, and in your statement you say many are opting out, and yet it's probably costing the state some money for this program, this life linkage line, and many are opting out. Are we getting a good bang for our buck? Are we spending the taxpayers' money wisely by law, requiring everyone to call this number and get a code before they can move into their loved one into a assisted living facility?
Whichever of you.
Well,
Mr. Anderson?
Chairman Abeler and members of the committee, I think the program is only 6 months old, and so it is very, very new still. And I think, although we don't know the exact dollars that are being discussed, I would say that I think some of the particular situations that we have worked with so far, as Pam mentioned, if it's not the current individual, the older adult that is moving into housing with services, I think in a lot of instances you have older adult children that are working with mom or dad or whatever. And so if it isn't particularly at this point in time, the hope is that helping educate others, members of the family, those that in the future will need services, I think it's starting the discussion at that point in time. Again, it's for mom and dad is the interaction we have. But I think in the future, as they grow older and become in a similar situation, I would imagine that hopefully they will recall the discussions they had for mom and dad and will help lend a broader perspective of what's available for them.
And Mr. Anderson, we need to move on, I guess, but with just one last question. Do you notice that from the beginning till now, people are more accepting of it and they're kind of taking the time to learn what you have to offer? More than the very beginning?
And Pam, I guess I would defer to you.
Yeah, again, I don't have specific data showing, from point A to point B, but I think in general, again, I think we as specialists are getting better at helping people to opt in as well, in terms of helping to create a safe place for them to talk about what's happening in their lives and in their families, and giving them an opportunity to talk with somebody about all the options available to them, not just one option of moving, which oftentimes I think people, think first, I've got to move out of my home, I've got to move to assisted living, and there are a lot of in-between options for them.
Okay, well, thanks. Oh, Representative Liebling, and then I'll give you you're the last question.
Well, thanks, Mr. Chair. It's more really of a statement. I mean, I've had just a little experience with trying to help somebody through this. I think this is tremendously valuable kind of a thing. I mean, this is really complicated stuff, and you don't, as an individual person, no matter how educated you are, how competent you are in your area of life, we don't do this stuff very much as citizens, or we only have usually two parents, and we just don't go through it that many times in life. And so to have one place where you have to touch base before you go off and make pretty expensive and long-term decisions, I expect that people will get used to it even being out there, and that I feel like it would be hard to assess after 6 months, and I feel pretty happy that we're doing this.
No, thank you. I think that's productive, and I thank you very much. There's an amendment coming up later, and I don't know when that's going to come up, but I don't know if we'll have more testimony to it, but I wanted to have it now while we're testifying. This has been a very much discussed topic, and I enjoyed our longer discussion we had privately, and I really see the value in your work. So thank you very much.
Thank you.
Ms. Perry, do you want to come down and talk about leapfrog? And I'm not sure if we'll this is the testimony part for that topic. I'm not sure if the amendment's going to come up or not, but I know it's been discussed. And Ms. Krinke, you want to come down and you want to be there? And I don't know if Ms. Braze is here. She could come down. And we're not going to spend a long time, but I just want to, you can do your thing. And we've heard, you were not here before, you can sit next to each other. And I know it's been discussed, and we had some testimony, but Ms. Perry couldn't be here, and I know she's been working on this for a long time, and persuaded me of the value of it, and so I thought that since she's here, and Ms. Finke, and Ms. Finke likes many valuable projects as well, I know, so welcome to the committee, Ms. Perry.
Thank you. Thank you so very much for allowing me the opportunity to talk to the committee today. I am here to talk about House File 2294. My name is Carolyn Perry. I'm President and CEO of the Buyers Healthcare Action Group. We're a coalition of public and private purchasers dedicated to healthcare improvement and market reform. In our more than 20 years of existence, we have consistently advocated for price and quality transparency so that people that buy health care, that is, the people that actually write the checks for health care, can buy appropriate services that provide value and result in optimum health outcomes. Ultimately, we believe that holding suppliers accountable for results will hold down costs by improving quality, eliminating waste, and avoiding mistakes. In 2002, we became a regional rollout for the Leapfrog Group patient safety standards for hospitals. We based our support on the Institute of Medicine finding that more than 100,000 people are killed annually as a result of mistakes made in hospitals. In keeping with our goal of quality improvement through accountability and transparency, we felt it was important to educate the public by providing them with information that made sense and was important to them. We asked that Minnesota hospitals report their performance in the Leapfrog selected measures and made that information available to the public. Initially, the National Leapfrog Group was not interested in having rural hospitals report to Leapfrog because it was originally intended just to measure performance of urban hospitals across the country. But because the Minnesota Hospital Association did not like the inference that there was a difference in quality performance between rural and metro hospitals, BCAG worked with the hospitals in Minnesota and the National Leapfrog Organization to define standards that would apply to rural hospitals as well as metro hospitals. This allowed Minnesota to be the first state in the nation to say that 100% of our hospitals reported to Leapfrog. BCAG applauded and supported the hospital's commitment to transparency and public reporting. The governor at the time proclaimed the announcement date as Patient Safety Day. We were all quite proud. Over the years, the hospitals have decided to pursue different avenues for quality improvement, and now public reporting in Minnesota is done primarily through Hospital Compare and adverse events reporting. A comment about Hospital Compare is that because of its methods, it's focused on Medicare populations, and therefore it doesn't measure all the things that employers or basic consumers under the age of 65 are interested in. In addition, because of its methodology, it shows that 90% of all hospitals participating are average. Therefore, all variation between hospitals is completely obscured. While we were instrumental in getting the adverse events reporting program started, we have always maintained that reporting adverse events, and remember, adverse events are those unimaginable tragedies, those things that should never happen in a hospital, like sexual assault of a patient or removing the wrong limb. We do not believe that reporting is enough. Leapfrog standards were developed to minimize and eliminate the risk of error. Simply reporting errors does not resolve the underlying causal factors. This year, only 11 Minnesota hospitals have reported results to Leapfrog. 4 of the reporting hospitals are in the top 3% of performers in the country. When asked why these hospitals participate, they say it is because it helps them stay focused on critical performance areas that affect patient safety. In a meeting last April with the Patient Safety Committee of the Minnesota Hospital Association, our employer representatives were asking why the hospitals did not want to participate in Leapfrog any longer. The members of that committee advised our employers that they have plenty of other things to report to, and really, unless they were mandated to report to Leapfrog, they did not have an interest in doing so. Before I finish, I think we need to be mindful of 2 critical dynamics that are in play right now in healthcare. First of all, employers are moving more and more toward account-based plans. Because individuals will bear more responsibility for the cost of their care, it is more important than ever that people have access to information that they can use when deciding where they should get their care. Patient safety should be a baseline expectation of every consumer, no matter where they are seeking care. Secondly, hospital-based healthcare systems are now consolidating to deploy arrangements called accountable care organizations. I have just one question. How and to whom is an accountable care organization accountable to? If these organizations don't even want to report their patient safety performance, then what is the true measure of accountability? Leapfrog is the only resource available to consumers that exposes variation in this most critical area of performance. If we can do anything to support the consumer and demonstrate that we as an industry are accountable to them, that they can entrust their health and safety to these institutions, then they must have access to the information. Thank you.
Thank you, Ms. Perry. Ms. Krinke?
Thank you, Mr. Chairman and members of the committee. For the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. As you all well know, the Minnesota Hospitals Association, as Ms. Perry just said, 10 years ago we embraced Leapfrog because it was kind of the first effort to really look at quality measurements. But since that time, dozens of other issues and dozens of other reporting mechanisms have now been established. Hospitals around the country, not just in Minnesota, but have dropped their participation in the Leapfrog program. And that is primarily due to the fact that Leapfrog is now 95 pages in length and very burdensome for hospitals to do. It takes a lot of FTE time to complete the Leapfrog survey. It's also self-reporting, so you don't know if you're measuring things exactly the same way as another hospital does. So you're not always comparing apples to apples and oranges to oranges. So it is a self-reporting system that means that hospitals aren't all doing the same thing. It also has little rural relevance, as Ms. Perry said. We don't want over half of our hospitals to come up as saying they have poor quality because they don't do all the measures on the Leapfrog reporting. Also, there's been less interest in the business community to ask for it. Quite frankly, this is a situation where you look at carrots versus sticks. If the business community and the purchasers were asking our hospitals to do it, I predict that more hospitals would voluntarily participate. The business community has lost interest in asking for Leapfrog, which is why we have gone from 100% participation down to 11 hospitals currently doing it. It's because none of the purchasers are asking them to do it. And the fourth one, which I think is the far most important reason that I want to mention, is that there are now other measures that measure quality widely across the country. Sorry. I think that, as Ms. Perry mentioned, the Hospital Compare website is very easy to navigate. I would ask you all to take 5 minutes and just type in the name Hospital Compare. You can type in a zip code and get the list of all the hospitals within a 25-mile radius. It is a very easy website to use. This is what hospitals are doing around the country. It has 5 categories that you can look up in terms of quality measurement. And I want to mention these because there's a button for each of them, and it's a really easy website to navigate. The first one is process of care measures. The second is outcome of care measures. The third one is uses of medical imaging. The fourth one is survey of patient hospital experiences. This is patient satisfaction scores. This is really an important component. The fifth one is patient safety measures. So you can go on this website. This is what hospitals are doing around the country. And we would ask that we do not need one more mandated government approach where you tell hospitals what government is asking them to do. It adds to costs and it adds to burden. So we were hopeful this year with Healthcare Reform 2.0 that the hospital community would not be given yet one more mandate that we have to do this year. So we're hopeful that this language can be taken out of the bill. Thank you, Mr. Chairman.
Mr. Perry, you're on 30 seconds, then I'm going to ask Representative Schomacker.
Well, I would encourage, and I would suggest that you all do, as Ms. Krinke has suggested, and go out and take a look at the Hospital Compare website, because I think you'll be fairly frustrated. We could make this dueling websites, but the Leapfrog Group website, if you go in and you just type in Minnesota, you get a list of all Minnesota hospitals across the state, and they'll be compared immediately right next to one another relative to how they perform on things that consumers have told them are important to them. Her point about employers or the private sector walking away from Leapfrog is, quite honestly, at some point you get tired of fighting. And what we're finding right now, though, is because it is more and more important that consumers have access to information, transparent and meaningful information, things that they have said are important to them, we need to jump back in and support the consumers in their quest for important information.
Thank you. Representative Schumacher.
Thank you, Mr. Chair. And this would be to both the testifiers, and you're kind of addressing it as it is, but I was wondering about the lack of interest from the business community on this, and was it sounds to me like it's maybe a chicken or an egg type of argument, which came first on, was it the business community became less interested because, and then therefore hospitals stopped reporting, or hospitals stopped reporting and therefore businesses stopped requesting information? Just if you could fill me in on that, that'd be great. Thank you.
Mr. Chairman, Representative Schumacher, when Leapfrog first came out, it was sort of the new thing, and so I think the business community was more excited about it. And as hospitals have become more transparent on price and quality, and we're going to have a discussion later today on provider peer grouping, there are a lot of other measurements out there. You might have seen in the paper last week, the Commonwealth Fund just released that hospitals in Minnesota are in the top quartile. St. Paul was ranked #1 in the country. Minneapolis was ranked #4 in the country. St. Cloud was ranked #7. I am amazed that out of all the communities in the country, we had 4 towns in Minnesota that ranked in the top 10. There are so many other measures now out there that in many ways Leapfrog was good at the time, but we have moved past that. And so to mandate now that hospitals have to go back to something that they did 10 years ago because they find it to be burdensome just seems out of line with what everything else we're doing. So.
Ms. Perry.
Might I comment? Because the burden is about 40 to 80 hours of time in 1 year for them to report to the Leapfrog survey. Again, the information is important to consumers because it makes sense to consumers. Originally, when the survey was developed, it was based on what was doable and what was understandable and what was important in preventing errors. Errors have increased since the Leapfrog survey has been diminished, and we're up to about 6,000 never events across the country on a monthly basis with the Medicare population. So never events aren't going away. As we walk away from these patient safety standards, I agree there are a lot of measurements that are going on, but the measurements are typically defined and endorsed by the industry and not necessarily supportive of what the consumers need to know.
Mr. Chairman?
Briefly, yeah.
I'm sorry, but I feel like I have to correct one thing. I don't think errors are going up. I would like to cite, this was a study that just came out. In 2001, there were an estimated 43,000 bloodstream infections associated with central lines in the United States, according to the U.S. Centers for Disease Control and Prevention. By 2009, the estimated total had fallen to 18,000, representing up to 6,000 lives that were saved and $1.88 billion in avoidable health care costs during this same 8-year period. I think hospitals are doing more and more on patient safety than they ever have been before. So I'm concerned about the comment that leaves that there's more errors than there used to be. We're reporting more. That is true. We have been much more robust in our reporting of errors. That doesn't mean there's more errors.
Ms. Perry, just 20 seconds.
Thank you, Mr. Chair.
Members
of the committee, I know. Well, here we have, and in 2010, an audit of Medicare, just Medicare inpatient admissions, showed that 1 in 4 beneficiaries was harmed in the course of a hospital stay, and 180,000 died of an unintended medical error. The OIG estimated that 6,000 never events, and again, these are never events, happen every month to Medicare beneficiaries in the United States. Because we get so confused about reporting and the importance of reporting, remember, Leapfrog is focused on patient safety reporting. That is intended to protect the safety of patients when they're in the hospital so they aren't unintentionally harmed. It's not all the other kinds of reports that they're doing just in the normal course of their events. This is seriously focused on patient safety, and it is for the consumer to understand and use when making decisions.
Representative Schumacher, you want one more question? Representative Liebling, you get the last question. Thanks.
Thanks, Mr. Chair. Well, if you're only focused on safety, why does it take 95 pages?
I don't even know I know that, for instance, on Joint Commission, well, first of all, patient safety is a huge issue, and there are so many things that can be done in order to focus on patient safety. I know that I used to be a risk manager, and so I worked in all the areas of casualty insurance and workers' compensation, and it is a lot of work in order to maintain safe procedures. This is in hospitals. I don't know how 95 pages compares with the other things they do, but I know that, for instance, with Joint Commission accreditation, they have full teams of people that they employ all year long in order to maintain their certification status. In relation to all the other things they do, I need again to reinforce that this is only 40 to 80 hours a year for them to report what they're doing to protect the public from unintended harm.
Ms. Krinke? And members, the reason I brought this up today is it's in the base of DE2, and there's an amendment to take it out, and you'll be asked to decide on that, and it's going to be a vote that you can take. So with that, thank you. We're going to change gears now. I'm going to go to the table. Ms. President Kiffmeyer is going to oversee for a while with the amendments that I brought forward, technical and otherwise. And then we'll be taking a break at 2:15, coming back at 30 minutes after session. So, and we have this room, so I would suggest most of the people in the chairs out here don't leave much stuff there, but if you want to leave your papers here, that's certainly fine too. Just that's the announcement. So,
All right. What number are we doing first? Okay. Members, just to let you know that all of your amendments are in order, numerical order, in your packets and your folders. So if you're looking for a particular number, that will be very helpful.
Madam Chair, I'd like to move the DE2 amendment.
All right, the DE2 amendment has been moved.
And we'll be working on that all day. There was a technical amendment which I would like, whoever wrote it, Ms. Cleveland, I guess, wrote that, and it's, I would like to move the A87 amendment, and I believe I have an oral amendment to that I need to make. Is that right, Ms. Cleveland?
Mr. Chairman, I'm sorry, you need to move the bill first.
I'm sorry, I'll move House 2294, be recommended to pass and be referred to the Committee on Ways and Means.
Thank you, Mr. Chairman.
I'll now move the DE2 amendment, and then I'll move the A87 amendment to that amendment.
Okay.
And I think, Ms. Cleveland, do I have to delete line 1.14? And Madam, Representative Kiffmeyer, I'd like to move to delete line 1.14, and should I just incorporate that?
Yes,
I can incorporate that. So line 1.14 is deleted. And if Ms. Cleveland would tell us all the technical changes here. I believe it's truly technical.
Madam Chair, what amendment are we on?
A87.
Oh, thank you.
There are a few amendments.
We need Mr. Chairman, we're just going to adopt the DE2 and then start doing amendments. The
That's
DE2.
fine, whichever you like. So, Madam Chair, I'd like to move the DE2 amendment to get the bill in a much different order than it was when it came.
All right, Mr. Chairman. All right, those in favor of the DE2 amendment, say aye.
Aye.
Opposed? DE2 amendment is adopted. Mr. Chairman.
I'd like to move again, I think for the third time, the 87 amendment with the incorporation of the deletion of line 1.14.
All right, motion to adopt
And
the
Ms. Cleveland can-
A87 amendment has already been made, Mr. Chairman, but just officially to do that, and then an oral amendment to your A87 is to delete line
1.14.
1.14,
And I'll incorporate that.
incorporating that in your A87.
And Ms. Cleveland could explain to us what the technical amendment does.
All right.
Please.
Madam Chair and members, this amendment really is technical. It just corrects numbers to reflect the spreadsheet, moves a rider that was in the wrong spot. it's really not policy at all. It's just
Thank you.
technical changes.
All right. All those in favor of the A87 amendment, please say aye.
Aye.
Opposed? Motion prevails. A87 is adopted. Mr. Chairman?
Madam Chair, and the next amendment, which is substantive and not technical, is the A88 amendment. I would move that, and I'll describe it.
A88 has been moved by Representative
Well, maybe
Brewer.
this is and I'll need some help from staff to make sure I don't forget something. Would it be better if the staff would describe it?
Which one of our staff will describe it?
Maybe they can just go through this. This is many items in here, and it may take some time to go through, and I'm not trying to hurry it off, but a lot of these are good ideas and have been brought by various lobbyists or needs that I've been working on. So maybe I'll let the staff go through them, and then I'll stand for questions.
Mr. Chung, it looks like you're getting the start here.
Madam Chair, members, I'll start. The first change is adding a Section 6 beginning on page 1. This allows the commissioner to provide nursing facilities with a special payment rate increase if the nursing home participates in the healthcare delivery system demonstration projects or other care coordination projects to account for the higher costs of participation. Then on line 16, it adds a section that modifies managed care withholds for medical assistance, and there are changes throughout. Page 2, line 11, this modifies the criteria for clinical or utilization performance targets. Then on page 3, this specifies the base year for when compliance is measured in calendar year 2012. This is for the withhold related to the use of emergency rooms. Then on line 25, this basically states that in comparing your performance, you factor in measures or differences in the health risk of membership in a baseline year compared to a membership year. Then line 30, this allows partial payments of the withhold. Line 36, that's the change in the base year. Then the remainder of this section makes similar changes to the other managed care withholds. Then turn to page 6, beginning on line 9. This is language that adds a $1 million increase in the money that goes from PMAP rates to Merck. Then the changes on page 7, lines 10 and 11. This relates to the managed care competitive bidding, and it eliminates language that would require rebids every 2 years. Then on page 7, line 13, this makes changes to the managed care capitation withholds that are similar to those described for medical assistance earlier. The next change is found on page 10. This is adding section 11. This is requiring DHS to issue an RFP to develop and administer a care delivery management system for medical assistance enrollees and specify some criteria for this system. Then on line 28, this is language from House File 1918. This requires the commissioner to develop and submit a plan to restructure and reform state health care programs, and it's tied to any potential changes at the federal level. Ms. Pinelli will continue.
Ms. Pinelli?
Madam Chair and members, starting on page 11, line 14, section 1 of Article 3 is being replaced with some compromise language that was worked out for Representative Pepin's bill on the child care assistance provider rate differential. And then on line 11.17, the differential is also being changed from a 15% to 16% differential. On page 12, the changes that you see on lines 12 through lines 26 are some technical changes and adding some specificity related to the foster care moratorium, the long-term care reporting, and then also the needs assessment. And then page 12, line 29, is the beginning of some changes to the MAEPD language. This is replacing what was in Representative Abeler's bill with the governor's language on MAEPD, and that continues through to page 15, line 14. Page 15, line 15 is deleting section 16 from Article 4. That's the caddy setting size and location section. The changes on page 15, lines 16 through 23 are more changes related to the foster care moratorium changes in the needs assessment study. The changes on line 15, page 15, lines 24 through the end of that page modify the home and community-based settings definition, and it creates an exception to that. On page 16, the section that's added is a rider section from the appropriations article last year, and the actual change is on page 17. It's modifying the rider for the reduction of rates for congregate living for individuals with lower needs. And then the next section that's being added starts on page 20, line 19, but the actual change to the language is on page 25, and it's modifying local planning grants for creating alternatives to congregate living for individuals with lower needs, and this is also tied to the foster care changes and trying to look at statewide capacity and doing the needs assessment. Then on page 26 at the bottom, starting on line 31, there's a section added giving the commissioner the authority to reduce the 2011 congregate care low needs rate cut if there are some savings that are generated from doing the needs assessment for the foster care. And then on page 27, the section that's added starting on line 7 requires the commissioner to submit amendments to the home and community-based waivers consistent with the definition that's earlier on related to the settings.
Is that everything?
Mr. Chair, I think the next section, page 27, line 20, is inserting a section related to children's mental health, and it's just making a technical change on page 28, lines 2 to 4. Then page 29, at the very bottom of the page, starting on line 35, there's a new rider related to the PCA relative care payment reduction, and it's just prohibiting the department from recovering that differential between the 100 and the 80% rate under certain circumstances. And then the rest, Mr. Chair, I believe is related to some changes related to riders. There's a new rider on the bottom of page 30 for transitional housing services. On page 31, there's a change in a rider. This is lines 4 to 9, changing the family assets for independence rider, granting that money to community action agencies instead. And then there's a new rider on page 31, line 13, for an autism study.
Thank you. Madam Chair?
Yes, Mr. Chairman.
There's a lot of detail here, and we thought it'd be easier to put them all together, and maybe that was a good idea or not. But let me just summarize. You've been given some of the detail of it, but in the overview, the first section on page 1 has to do with emergency medical assistance. It's a relatively complicated part, but this is, if the department has this, they can manage within their own capacity to look after this problem. And I can tell people more offline. lengthy chat about that I'd rather not do now just because of time. The second part is from the HMOs, and I think that's in order. Has to do with their withholds they can get credit for. And some other really nice things here. On page 10, I visited United Health last 2 weeks ago, and section 11 on page 10 is the product of that. I was impressed with their capacity to analyze data, and whether it's them or somebody else, but it seems to me like there's some way we can improve our fee-for-service programming. It's meant to be friendly to the department. It's friendly to quality and cost, so that's what that's about. And I'm pretty excited about section 1 on, these are all different numbers, page lines 11, 14, with the, we can increase the accreditation rate differential to 16% and deal with these other providers. I think that'll be helpful. And I'm happy we can do the governor's version of MEPD, which is superior to the one the House had worked through. So I hate to admit that, but it was better, and it can be retroactive to April 1st for the people who are in that program, which is even counting a later effect. We can pass it, and it goes back to the beginning of the quarter. So the people you saw here who were still able to be rescued are good to go, and they can work until they're 100 if they want, and retain $20,000. So it's not even a 67-year-old thing, which we had been talking about. So it was about $100,000 more than what we had in our bill, which I tried to find the money to pay for. And probably one of the biggest single things on page 15 is on line 1531. There's 25% of the units, and we want to make sure we take care of Mr. Nelson's concerns about harming the small size projects. But there's been a whole challenge about letting people do more supportive living, assisted living in communities under the Caddy waiver and others in places that are larger than 4. The current standard is 4 people in a 1,000-unit apartment building, which just seems unreasonable. And there aren't many 1,000 units, but that would be the standard in that place, one roof or notwithstanding. This will allow up to 25%, and so 25 and 100-unit place could be places like this. They would meet people, and you get some economies of scale, and there's just some wonderful service being provided there. And this, I think, opens the door to great innovation, which allays my concern about the impact on the corporate foster beds. And the whole point of this management, which that Ms. Henry brought forward as one of the amendments, the 8th amendment on a bill we did a few weeks ago, about managing to get rid of the bed closures, which I really did not like, but managing it wisely as a system to make sure people are served in their best site. It will be done in a careful way and with communication with providers and clients. And I do believe there are too many corporate foster beds. I believe the way out of them has been a roadblock because of this very matter about 25%. If we can get this to go, and the department agrees with this number, we can actually unlock these programs to give these people, that's the wrong way, this group of individuals a much better chance to have a better life. And I'm excited about that. This may be the marquee accomplishment of this session in reform in this bill. So I've been working on that since November. Anyway, a few other highlights. And this, it's just a bunch of technical stuff, but let's see, there's a couple other things that I'm really excited about. The PCA, the recovery language about that we're going to look forward from the judgment. This means that for the operators who've been withholding 20% out of fear we're going to claw it back can now send a check to the PCAs they employ, and it could be Christmas in June when that comes. So that'll be nice, and so we can look forward, and I think that's a good way to do business anyway. And finally, on page 31, the autism study. There's 2 parts, and there's 2 parts. One is to get on autism, in particular with regard to the Somali community. I'm not sure if it says that. It says cultural, I guess. It says Somali, yeah. But they have an incidence of like 1 in 26 or something Somalis. Also, I'm told in Norway. So they do fine in Somalia, and they come here and whatever. We don't know. It's really terrible that they have a child and 1 chance in 26 to become autistic. And so we're the House is leading the way in this, encouraging the department, giving them some money to start looking into this. There's some small studies going underway now with the U of M to study if it's really a problem. That's the project currently. That's research for you. We all know there's a problem. They're going to confirm there is one. This is going to get them going to see, why is this problem? They're going to confirm a problem. What's the difference? And so perhaps using some graduate students, and what a great place to go with your master's thesis, to study this very important group. And then they're going to come back with some recommendations about how to improve surveillance. So it's a two-part thing. So for those of you who come back next year, you'll get to hear the report of this. So, and just overall, Madam Chair, there were some problems that I promised I'd work on. One was the impact on the caddy folks, in particular, the 10% rate cut when they're concentrated in supported living services. One thing in the bill that I don't know if it's going to work, but I tried to take an even proportion of individuals in both the caddy waiver and the DD waiver to have the 10% rate applied to, which I think disproportionately hit the low-need caddy folks, which could put some of these very successful sites out of business. So there's language in there. I told people I would get rid of the bed closure, the mandatory bed closure. They are gone. If closures occur, it's because it's reasonable to close them and because there's some agreement and a process in place. So that's the point of this. The rate cut for low needs, I didn't like 10% in the first place. The House didn't do it. It just came out of that process. I don't know, do we do that? We might have, I don't remember. Take back that sentence. But I didn't like it. And so the money that we save, if there's savings beyond expectation in these managements we're doing, we're not going to let it drop to the bottom line. It's going to go into the rate reductions. We're going to capture it and put it back into the system. And that's, I think, really important. And finally, on the PCA matter, thanks to the litigation, it saved us $15 million of the savings we took that wound up in the forecast. And I said we have the clawback language fixed. So to the best of my ability, with a very small budget, I think we've solved a lot of big problems, at least help them be ameliorated. So that's the amendment, Madam Chair, and I'll stand for questions.
Thank you very much, Mr. Chairman. And we do have a question. Representative Hosh, did you?
Thank you, Madam Chair. And, just to try to get my mind wrapped around everything, because we had a DE1 amendment, a DE2 amendment, and now a significant 31-page amendment to the DE2 amendment. I don't know if it's a realistic request of staff, but is there a way we could possibly get kind of an unofficial and gross version of what the bill is going to look like when we reconvene? Because there's a lot of technical insert this, delete that on this amendment, and I want to make sure that I'm reading it correctly. And it's just a thought that I had. It's a good idea.
Mr. Chairman, we have. Would you like to comment to that?
Well, I don't know if it's realistic.
Yeah.
I know when Representative Huntley's first year, we had a 50-something page amendment late in the process, and we worked off of that, and that's just kind of how it gets to go. But I see Ms. Pinelli nodding. It could be done.
Mr. Chair, members, we could have staff up in House Research just put together an unofficial engrossment of this with these two amendments put into the DE2 amendment.
Okay, well, if that can be done, then let's just put this aside and go to other amendments, and then you can read it over in the break. And I'm not trying to rush anything. It's just a lot of these topics are not new.
Thank you, Mr. Chairman. And Representative Hosh, I have a technical from Mr. Chun to this A88 amendment. Just a quick thing. Let's take care of that, and then we'll go back to.
Sure, Madam Chair and members, this amendment would be on page 8, and this is the A88 amendment. So on page 8, line 34, you would strike 2011 and insert 2009. This is related to the Minnesota Care Withhold. It just corrects the language to match up with the other changes made.
Madam Chair, I'd like to make that an oral amendment, if I can, on line 8.34, strike 2011 and insert 2009.
Mr. Chairman, that is an oral.
And I can
incorporate it into your A88 amendment. It's a technical issue. That is acceptable. All right, you have the A88 amendment in front of you. Representative Hosh, you've got your answer, right, on that?
Madam Chair, I did, and I want to thank staff for that flexibility. I don't want to be overly burdensome, though, so if it's an unrealistic request, I would understand. It just allows me to wrap my head around all the changes for me.
Representative Hosh, I'm sure they'll do the best they can. Ms. Pinelli?
Madam Chair and members, I just want to be clear, if we put together an unofficial engrossment, all of the amendments that we're going to be doing throughout the day today are still drafted to the DE2, so you wouldn't want to be looking at the amendments and trying to match them up to the unofficial engrossment because the page and line numbers wouldn't work.
Representative Haas?
Madam Chair, I completely understand that. I just want to make sure if there's something that arises from the A88, if we have to make a change. I'm reading things correctly, but I don't know how many amendments we have today. I'll still be referencing the original DE2 amendment, knowing that that's
Representative
what
Haas,
everything's written to.
it's very important that, there's a lot of amendments, and staff needs certainty as to what they are. But I think just as a reference document, the unofficial engrossment will just be a reference document for your use. All right. Representative Liebling?
Yeah, thank you, Madam Chair. And I was going to also say that, this is really hard. We've got a lot of amendments. We've got a lot of, different things flying around here, a lot of different issues. And, if staff can produce a copy of an unofficial engrossment, I think that's fine. But frankly, for me, it's probably just going to be that much harder to handle yet another bill here at the table. And I'm looking around, and we've all got these piles. So, I don't know. I wish there was a way. We haven't yet hit on the real easy way to do this, to organize all this. I know everybody's equally confused. But I also do have a comment to the amendment itself, if I may.
All right, Representative Liebling.
Thank you, Madam Chair. And Representative Abeler, in that quick run through, most of this I'm okay with. With one thing, though, jumped out at me in this, if that's okay, and that's on page 10, section 12. You've put in there this, what was essentially was Leader Dean's bill about, the what I would call the amendment, the bill that kind of freaks out about what the federal government might be doing and says, let's make the Department of Human Services and, the Health and Commerce kind of jump through some hoops just in case, everything around us comes crashing down, if the apocalypse should come, what are we going to do about it? And, and I know there was a letter from, I don't know if it was from some of the commissioners or from the governor himself kind of objecting to this and saying that they don't feel this is necessary. I mean, maybe somebody here would like to come and comment on it if anybody is here, but
Madam Chair.
I find that a little troubling.
Mr. Chairman.
Are you on page 10, section 11?
Section 12, Mr. Chair. Page 10, section 12.
This is the Gottwald bill, I think. So this was heard in reform, and this is incorporated in its entirety. And it was actually, I would have rather been, I think it's also an amendment, but it just got stuck in my amendment, I think, just because of process. Maybe I asked Representative Gottwald about this section, if I have that right. So section 12, page 10.
Oh.
Representative Liebling.
Thank you, Mr. Chair. Okay, I might be confusing
The Dean bill is not in this bill, Madam.
Okay, thank you, Mr. Chair. I might be confusing two things that are kind of going to the same place, and maybe the administration had commented on the other one. I'm not really sure, but it's kind of the same idea, and that is that we should have these sort of, for lack of a better word, to call them disaster plans. Okay. We're going to make our agencies do so. Maybe I don't know. Maybe. If this,
always be prepared.
Madam Chair.
The Boy Scout bill, I guess we could call it.
Madam Chair, this bill makes no provisions for any disasters. We're just going to take them as they come. So.
All right. Okay. All right. Thank you, Representative Liebling and Mr. Chairman.
Madam Chair, should I hold it over then and move to another amendment? Would that be
Well, Mr. Chairman, I think in order to do this engrossment, staff said that they need us to adopt the 8088 amendment.
Oh, okay.
Well,
is that all right?
Chair.
You can still move to delete things if you want later, of course.
Well, I was going to ask whether I would make that motion now or after we adopt the amendment.
Either after it's adopted.
Okay.
Mr. Chair, we have the H229488 amendment before you, members. All those in favor say aye.
Aye.
Opposed? Motion prevails 88 is adopted, and staff will be able to do that.
And Madam Chair, maybe if there's motions to delete, we can do that later. If we can go through the topics that we have and people can, I mean, I'm not afraid of any deletion of motion, but then we can maybe chat about why people think something should go. And it's my intention to have nothing provocative to the administration in this bill. We've had an extremely collegial relationship. On the way out of this committee and on the leaving the House, the last bill had some things I'd consider provocative. This is not a provocative bill. It's a different time. It's a different purpose. This is a bill to get things done and try to solve problems. The administration and the departments have been extremely helpful in putting this together. They didn't think of all this stuff. They don't embrace it, but they have made it reasonable. And some things they're actually glad we're working on. So my goal is to get a bill signed that can leave the floor. It can leave the floor with actually bipartisan support and get signed at the end of the process. So just so people know what, if he thinks there's a stunt here, tell me about it. I don't want to have any stunts.
Okay. Just to remind you, we just have another couple minutes, and Representative Liebling.
Well, thank you, Madam Chair. Well, I just kind of want to know what process you'd prefer here then, Representative Gottwald. I mean, I'm happy to do that, and I understand that that's your intention, and, you know, there's so many little pieces to keep track of. Maybe we will want to take testimony on some of these issues, so should we just sort of set this aside for now, Madam Chair, and come back, and maybe you'll want to have somebody speak to it later.
Well, Madam Chair, we have a 2-hour floor session coming, and perhaps we can have discussion on the floor if people have specific concerns. These amendments were posted yesterday at noon, or early, they weren't. They weren't. They were posted. They were given to your caucus earlier. Oh, they didn't. Did they get to their caucus early?
Well, Mr. Chairman, just to remind you that.
At 5:59. Okay.
That again, we are functioning on amendments to the DE2. And so any amendments we take up at this point will be to the DE2, so that when you're reading through them, that you'll be able to see that you read the DE2 and then amendment to that, and then we'll have the unofficial engrossment kind of be able to look at the A88 to the DE2. Right. And Mr. Chairman and Representative Liebling, when you come back, just to help you in regards to if you want to take an action on the A88, when we get back, you can do that yet. That will still be part of the process that you can do. All right, we are at our time, members. Mr. Chairman, we are recessed until 30 minutes after session.
Madam Chair.
Thank you, Madam Chair.
You can leave our stuff here.
Representative Gottwald, you can leave everything here, yes.